We're gonna go ahead. Thank you. We are gonna go ahead and get started because we've got a lot to go over today. So welcome to the third session of our Centering Trans and Gender-Diverse People in Public Health. Today's session is Gender Diversity in Public Health and Clinical Programming. And if you want to just go to the next slide. The training is not a definitive guide. I mean, this is not a definitive guide, but it's really intended as a starting point for implementing gender-affirming care and culture in your clinical programs. I do want to note for any folks that weren't able to attend the first or second or both of those two sessions, we do recommend reviewing those recordings of the trainings when they're available. First, because they were awesome trainings, but hopefully to give you better context for this training. Next slide, please. Next week will be session 4. That'll be January 30th from 1 to 3 p.m. Eastern time, and it is our next steps, and it's the fourth session in the series. Next slide, please. Okay, so since I'm talking, you can meet me first. My name is Billy Golden. I live in southwestern Ohio. I'm a manager on the drug user health team at NASTAD. Prior to working at NASTAD, I worked in direct services, mostly in harm reduction programming in the Cincinnati area. I came out as trans in 1997. I began medically transitioning in 1999. And my interest in participating in this training really comes primarily from having seen in the last 26 years a lot of poorly designed systems of care that left trans people out. So having an opportunity just to help share some information that could help improve any sort of trans-related care or services was something I really wanted to be part of. I see folks are introducing themselves in the chat. That is awesome. Zoe, you want to introduce yourself?
Absolutely. Good afternoon, everyone, and thank you, NASTAD, for inviting me to be here. So my name is Zoe Peach. I use she, her pronouns. I am the prevention team lead and health educator at Caracol, which is the AIDS service organization in Cincinnati, Ohio, where I had the pleasure of working with Billy for a number of years in the direct programming side of things. So I'm a trans woman. I have been out since 2014-ish. Everyone's journey is a little bit messy and complicated, mine included. And I started medically transitioning in 2015. And my experience over the years, it's been very positive with most of the healthcare systems I've interacted with, which is very lucky that I live in Cincinnati, Ohio. I have access to state-of-the-art care through academic medical centers. But when I first started transitioning, I started transitioning in college. And there were definitely some challenges accessing care when I was in college. So that's kind of what brought me to this training as well. And Billy, being an old friend of mine, I was more than happy to help out. So I am so excited to get into the content with everyone today.
Thanks, Zoe. I'm excited to get to present with you. Juan, if you'll hop on. Well, actually, it's about NASTAD. If you've been to the first two sessions, you know about NASTAD. And if you don't, I'm going to let you read this one on your own. Next slide. The group agreements, again, we have gone over them in the previous two. Nothing's really changed, so you can look these over. But really just want to say, let's remember to come to this conversation, if at all, if you choose to do so, respectfully. Next slide, please. If you have not guessed, we're going to be moving a little quickly today. We have a lot of material. If you have slides printed out on your computer or you're looking at them on your computer, we aren't going to be discussing every single slide. Some are there just for your reference. We also have an extensive resource list at the end of the presentation. And because we're going over so much material today, we're going to ask folks to put questions and comments in the chat box. Our colleagues Robin and Juan will be monitoring that for us and answering questions unless it's something pertinent that Zoe or I answer. So with that being said, next slide, please. Here's a glossary of acronyms. I am not going to go over all of these, but I just want to make a note that I am going to use the term trans as an umbrella term that also includes non-binary and gender non-conforming folks as appropriate. Thank you. Next slide. Okay, so for anyone that was on last week's session, it was a pretty deep dive into trans history, and it was pretty intense. We have been around for a long time. There is a long history of hatred towards trans people, but there's also a longer history of cultures that have normalized and valued gender diversity and trans folks. Trans folks help lead the forefront of the LGBTQ movement in the United States. We've been around for a long time. We do face microaggressions daily, macroaggressions, stigma, violence, personal and political attacks that are meant to erase us. There's a lot of stuff. And these effects have really huge repercussions on our physical, mental, and spiritual health. Always I want to make sure to, note, like, particularly trans people of color and other folks, trans folks that have intersecting marginalized identities are going to be even more harmed. I do just request today that folks on this call keep at the forefront of their minds the effects of transmesia. And as a reminder, that was trans hatred. Survival often takes precedence over healthcare. So I would say make sure to consider that, and also think about like wonderful things about being trans and our well-being, and how can your organization help to foster that. So thank you. Next slide, please. Okay, so fun stuff here. Basically, we have a slide here that is from a study on trans data collection in electronic health records. It came out in 2022. It really pointed out a need for comprehensive trans healthcare. Out of 365 medical students that were surveyed in Canada, only 6% felt sufficiently knowledgeable to care for trans people. Next slide, please. This was cited in this study, but from the 2015 US Trans Survey, out of roughly 27,000 trans people that were surveyed, 33% of them reported having a negative experience with a provider within the last year. Next slide. And that same study showed that out of 132 medical schools in North America that were surveyed, there was an estimated 1,100 hours of schooling, and only about 18.3 minutes of that were spent on trans health care. So that's not a lot of minutes to try to educate our future healthcare providers. Next slide, please. In 2021, the state of Connecticut had its first LGBTQ plus community needs assessment. And a lot of the data in there echoed some of the national data. Many respondents felt that the healthcare system does not meet their needs. And the next slide, I'm going to skip over the next slide, but it's just got a little more info about that. And we're just going to kind of go into gender affirming care. So what is gender affirming care? Basically, it's a term that can involve a range or any combination of services that might address physical, mental, and social determinants of health. It helps encourage trans folks to live and thrive as their most authentic self, gendered self, non-gendered self. It's not a cookie cutter type of care, and it's going to be unique for each person. But at the forefront of it, people need to feel safe, and the care needs to be accessible. Next slide, please. I'd love it if folks wanted to go ahead and put in the chat box any examples of gender affirmation that we have for cisgendered people. And Juan, if you'll go to the next slide, I'm going to talk about that a little bit more. So gender affirmation is not a new concept. It is so deeply ingrained in our society, and it's normalized for cis folks. It's normalized so much that we don't really think about it. It starts at a young age. I did an internet search for toys for girls, and there were 31 million results. I did a search that was toys for boys. That was 22 million results. And gender neutral toys had 722,000 results. And I am hoping those were mostly children's toys. I forgot to put that in the search. But that's a fairly big difference. Yeah, and I'm looking here like makeup, breast augmentation, hair transplants, working out to build muscles, language, conjugation by gender, gender assignment to inanimate objects, laser hair removal. Like, yes, things are very targeted. The colors blue and pink, deodorant for a man versus a woman. It's very deeply ingrained, but it's not necessarily deeply ingrained for us trans folks. Yeah, exactly, Robin. Erectile dysfunction meds for cisgendered men. So, yeah, the point, gender affirmation is not new. Next slide. And this next slide, it's just a brief timeline of westernized trans healthcare. I'm not going to go over it. You've had a history, like, we've already done the trans history. It's for your reference. And Juan, if you'll skip to slide 20. So the slide after, yes, thank you. Actually, if you'll go ahead and go to the next slide, we're going to cover transitioning now. Social, legal, and medical. So fun stuff. Basically, I want to emphasize there is no one right way to transition. And for some folks, they may only go as far as any one of these points or not at all. But social transitioning really involves or could involve the change to a social role. That might be asking your family, friends, coworkers to use different names, different pronouns. It might include how we identify or how others identify some of our social roles. I got to become an uncle in 2001, where I might have been an aunt a few years prior. Maybe a brother goes into a sister. We might alter our appearance or not, so it better aligns with our gender. That could include clothes or hair, or makeup, how we walk, the inflections in our voice. There might also be behavior changes that can, and those can be from increased awareness, like a self-awareness, could be more confidence. And I think that some folks consciously pick up traits that they perceive to be more masculine or feminine or neither, in order to better be perceived as their chosen gender. Next slide, please. Legal transition. This is a fun one. It's not always easy to know. It's not something you do on a whim. It's not that easy. Just looking at this slide, it's important to note that not all these steps are applicable or even accessible. Unless you're filing for something like a federal document, like a passport, the requirements are going to vary state by state. So you might be in a state where you can only change your gender marker on your ID if you can change your birth certificate, but your birth certificate might come from a state that doesn't allow you to change your gender marker. Or you might be in a state that just doesn't allow gender changes on your ID. Or you might be in a state where you can only change things unless you have proof of gender-affirming surgery. It's complicated. Next slide, please. So these are legal transition info on legal transitions in Connecticut, and Connecticut is actually relatively low barrier. But even with that, all of these steps are complicated. They can be made harder by uncooperative administration. There's barriers like cost, transportation, job flexibility, housing stability. Uh, anything you have, basically, you have to have the financial means, the time, and the know-how to navigate the systems. Next slide, please. Oh, whiz through that. Zoe, you're up. Thank you,
Yes,
everyone.
indeed. Thanks, Billy. So I'm going to be focusing a little bit more on the medical transition side of things. Next slide, please. So I do want to start off with a lot of caveats. As Billy has already mentioned, transition doesn't look the same for everyone. Medical transition is only a small part of an overall transition that a trans person undertakes. And transition looks different for everyone. So there are a few things that are going to box us into a little bit more of a category than necessarily I would like, but just due to the nature of the medical treatments that we have accessible for trans folks right now, that's kind of the framework that we'll be working with. So I will primarily be referencing something called the WPATH 8, the World Professional Association for Transgender Health, so much easier to just say WPATH, Standards of Care. And they've been publishing this since the early 1980s in some form or fashion. And it is a compendium of all the different recommendations of the different studies that have been undertaken into advising medical practitioners on how to provide clinical guidance to, they use the term TGD, so transgender and gender-diverse people, in accessing safe and effective pathways to achieving lasting personal comfort with their gendered selves, with the aim of optimizing their overall physical health, psychological well-being, and self-fulfillment. I know you all can read that, but I do want to emphasize that at least the WPATH guidelines use a rather modern interpretation of things that isn't necessarily very restrictive to one path of transition, as may have historically been the case. Historically, we would often see a path of transition that somebody would see a counselor for 6 months to a year. They would complete that counseling, get a referral letter, which I am putting in quotes, get that referral letter, and then begin medical transition with pharmacological therapies, which I'll cover first, and then undergo pharmacological therapies for some number of years before moving on, again, in scare quotes, to a surgical transition. The current guidelines, the WPATH, which is the primary source, as I mentioned, for these slides, along with a number of other guidelines, the Endocrine Association has some guidelines for treatment of trans and gender diverse folks, and the University of California at San Francisco is also another primary source of mine in putting the medical transition side of things together. So WPATH specifically uses this phrase gender incongruence, and they mean that to not be pathologizing. Specifically, they say that any psychological distress that is encountered by trans folks is socially induced and is not inherent to their trans identity. So let me just repeat that again. The mental health issues, the number of issues that trans folks run into that Billy and I have mentioned so far, that you've learned about over the past couple of weeks, those are socially induced and not inherent to a trans person's identity. Further, the WPATH really emphasizes a multidisciplinary approach in the medical transition side of things, with endocrinology, general surgery, voice therapy, primary care, along with specialists who focus on sexual and reproductive health. For a little bit of self-disclosure, I received my hormone therapy from a primary care provider who primarily treats other trans patients, and she's affiliated with a major academic medical center. However, I have a strong connection to rural areas. I grew up in a small town of 6,000 in Southern Illinois, and anything like that, I could barely dream of something like that in Southern Illinois. And currently my parents live in Central Kentucky, where there isn't access to a major academic medical center. So recapping from that, the WPATH guidelines are meant to reach a particular goal for binary identified trans people, But again, this goal is very flexible and should be patient-centered. But for binary identified trans folks, what the guidelines are aiming for and what most people, not all, but what most people aim for are targeting those serum levels, so the testosterone and estrogen levels, to target those associated with that person's gender identity. So for me, we would want to target testosterone levels that cisgender women have, and we would want to target estrogen levels that cisgender women have. Next slide, please. So I'm just going to briefly go over this as we've done with the other slides. I want this here as a reference. So trans folks have complicated feelings about their bodies, and those complicated feelings about bodies really show up when we present into medical spaces. So this is just a brief list of a few alternative medical terms that are recommended instead of some more traditional terms that we may think of. And this is one of the ways that we can create a gender-affirming care environment. Next slide, please. And this is some additional terms. Next slide, please. All right, so now we're gonna start off going into the pharmacological therapy side of things before progressing into the surgeries, and then we'll talk more about, creating an inclusive clinic environment. Next slide, please. So we'll start off with talking about feminizing therapies. So typically for any kind of feminizing therapy, there's estrogen prescribed along with some form of androgen lowering medication. They can be prescribed by themselves, but say for a binary identified trans woman like myself, I am on estrogen along with that androgen lowering medication. For those of you that may be a little bit more familiar with trans health, there's a lot of controversy around something called progesterone. Most of the guidelines, so the WPATH guidelines explicitly say progesterone doesn't have any value and there are some safety concerns. While the UCSF guidelines say that there isn't any proven value, but there's also no significant safety concerns. So progesterone is a significant controversy in the trans health community for trans women and other folks seeking feminizing therapies. But in short, most of the time, what you're going to see for any feminizing therapies are estrogen of some form, along with an androgen lowering medication. So estrogen can be administered through a few different routes. There are some different options, more options than our transmasculine friends have, in fact. So pills, which I'm on, there's a transdermal patch, so a patch that one would put on their skin, or self-administered intramuscular injections. And for a bit of personal history, I have went through all three of those. And each one of them have their own risks and benefits. Overall, the transdermal patch is somewhat preferred for its safety profile. We'll talk a little bit about some possible side effects in a couple of slides. But the transdermal patch has a slower absorption of estrogen, so that is slightly preferable safety-wise to the pills in the intramuscular injection. Now, coming from the HIV and viral hepatitis world as NASTAD and my own organization, Caracol, has, whenever we talk about injections, our mind automatically goes to bloodborne pathogens. So it's relatively rare that we see trans folks sharing needles for intramuscular injections, but it's an important thing to consider. So for those of you that are in the public health realm, that may participate in harm reduction programming, it's important to consider that you may be serving trans folks. And trans folks, due to the medical barriers and social barriers and the numerous other barriers that we've talked about, they may not be able to access this care through traditional healthcare settings. So they may be receiving estrogen on the streets. And when they're receiving estrogen on the streets, there is that risk that they're not getting their syringes from a reputable source. Alternatively, I know when I was on injections, my insurance, which I have good insurance, I'm employed by an AIDS service organization, and I was still had significant issues with my insurance covering syringes. So occasionally you do run into folks that are sharing syringes for their intramuscular injections. As for laboratory monitoring, which I think most of you all on this call are more in the case management, social work, general public health side of things and not directly on the clinical side of things. Folks who were on feminizing therapies during that first year, they're going to go in for laboratory monitoring about every 3 months or so, and then a couple of times a year, 1 to 2 times a year, once that maintenance dose has been attained. And that's usually over the course of that first year. Usually, feminizing therapies are titrated up, which can cause a little bit of frustration for folks that are newly transitioning. They want that maximum effect as soon as they can get it. So the titration is there's a couple of reasons behind titrating the doses. One of them being that we've seen with some well-controlled, well-established studies that if you titrate therapies, you receive better results. Most significant of those, often to trans women, is breast development. And over time, if folks titrate the therapies instead of starting at that high dose, starting at a lower dose and going up, it seems to have better results for breast development. The other concern is, of course, the safety profile. Hormone therapies are safe and well established, but there is a slight concern, as we'll get into a little bit later, with some side effects. And by starting at a low dose and continuing that laboratory monitoring about every 3 months, medical practitioners, folks in the medical world, are able to get a pretty good hold on any of those adverse effects. Next slide, please. So we'll start off, though, with some desired effects that we see of feminizing therapies. So one of the most immediate things we see is a softening of the skin, generally thinning of the skin as well, and it dries out a little bit. So folks who may have some pre-existing skin issues, like me, I have a couple of different skin conditions. Sometimes when they start feminizing therapies, that can really aggravate or unmask certain skin conditions. We also see generally decreased muscle mass and redistribution of fat and redistribution of muscle. So I particularly use the word here, changes in facial and body hair. So estrogen and the androgen lowering medications, unfortunately, do not eliminate facial or body hair. They usually will significantly slow the growth. The facial and body hair will get softer and lighter, but it will not go away completely. In addition, as I was mentioning a while ago, breast growth is, of course, another one of the major desired effects. Unfortunately, feminizing therapies will not change bone structure, height, pitch of voice, nor will the Adam's apple shrink, which we'll talk a little bit about surgical interventions in a couple of slides. It usually takes about 3 to 5 years for folks to see the full effects of feminizing therapies. Next slide, please. There are some side effects associated with feminizing therapies. And these, again, this is a rather controversial topic in medicine. There aren't a lot of longitudinal long-term studies with hormone replacement therapy, as this is an emerging body of research as we have moved it from a psychiatric condition into one that medical practitioners can help with, rather than trying to cure people. Medical practitioners now are trying to help people live with their most authentic gendered selves. But we do see somewhat of an increased risk of blood clots. That's the number one. Ever since I started on feminizing therapies for the past 9 or 10 years, that's always been hammered into me by every provider that I've seen, is that increased risk of blood clots. There is also an increased risk of cardiovascular disease, but we especially see that with some of those traditional risk factors that we see for cardiovascular disease, like older age, tobacco use, pre-existing conditions, or any family history of cardiovascular disease. I do want to emphasize tobacco use should not be a contraindication for initiating feminizing therapies. I had a friend of mine 10 years ago when I first started transitioning. She was pursuing hormone therapy at the time too, but she was a smoker. And at the time, the provider that she was seeing would not start her on those therapies until she stopped smoking. There's no need to do that. The WPATH guidelines and the UCSF guidelines emphasize that yes, smoking does increase that risk of cardiovascular disease and blood clots, but instead of being contraindication for therapy, it should be approached with a harm reduction lens, and patients should also be informed at each visit of tobacco cessation strategies. Research for the rest of these, research is pretty unclear about these, other than loss of erectile function, which again, that kind of straddles the line between a side effect and a desired effect. There's possibly an increased risk of developing diabetes, but the research on that is quite unclear, along with gallbladder disease, liver inflammation. More clearly, since headaches, especially migraines, are hormonally linked, there is an increased risk of developing migraines or worsening any pre-existing migraine condition. As for the androgen blockers, there is significantly increased urine production, especially when folks first start on the androgen blockers, which usually, by the way, the most common androgen blocker that we see is called spironolactone. And there's also increased potassium levels, but the potassium level increase is usually not enough to be of a clinical concern. There is also a possible loss of fertility, but time varies greatly from person to person. So that's another one of those things. When I first started on hormone therapy, when I gave my informed consent to begin feminizing therapies, there was a lot of discussion about that possible loss of fertility. And you see that often pop up as well in the current discourse about medical treatment for trans folks is about that loss of fertility. So that does happen over time. It may or may not be reversible. It really seems to depend on the person, and that time varies greatly from person to person too. I did see that we had a question in the chat about is it an increased risk of blood clots compared to cisgender women? So with feminizing therapies with estradiol, yes, it is an increased risk compared to cisgender women. But for any cisgender women that are on hormone replacement therapy later in life during menopause or something like that, the risk is it is the same. However, the risk is a little bit higher for trans women overall, just because of the longer length of time that they're on that feminizing therapy. Next slide, please.
Before we move on, we did get another question in the Q&A.
Sure.
Is there an increased risk for any cancers due to very long long-term use of hormone therapy as people age?
So there's been pretty mixed evidence on that. Historically, we did think there was an increased risk of breast cancers, but as we've gotten better data over the years, it looks like that risk isn't necessarily there. So that's a very good question, since again, that's a bit of a controversial topic in the world of transgender medicine that we don't have a super great handle on, but the answer to that is probably not. All right, so now we're going to move on to masculinizing therapies. So masculinizing therapies consist of one thing and one thing only. A little bit easier to manage from the medical side of things, if anything, testosterone. So the options for administration most commonly used in the US are the intramuscular or subcutaneous injections. Transdermal patches and topical gels, they are available in the US, but a little bit more rare. And then outside of the US, oral tablets are available, but they have not been approved by the FDA in the US due to some concerns about more significant side effects. Specifically, there have been some cases of fulminant hepatitis associated with those oral tablets. And since we have those safer options, the FDA has chosen not to approve those yet. As for laboratory monitoring, it looks very similar as it does for trans women. So it's every 3 months for that first year, and then every 6 to 12 months. For those of you who are maybe case managers that are working with folks and wondering what those lab values are, we do have that list of resources at the end of the PowerPoint that I would invite all of you to look at, that has a list through the UCSF guidelines and the WPATH guidelines of what that laboratory monitoring precisely looks like. Next slide, please. So let's go into the desired effects of masculinizing therapies. Number one is that some, but unfortunately not all, transmasculine folks will experience the stopping of menstruation, usually within about 2 to 6 months. that often is a pretty significant source of dysphoria for transmasculine folks. And one of the things that we may want to do as well, instead of using the word menstruation, is using the term monthly bleeding is one of the options, since that can be such a significant source of dysphoria. So with masculinizing therapies, with testosterone, the voice will deepen, but it takes about 1 to 2 years to take full effect. Facial and body hair will start to grow within 3 to 6 months of starting HRT hormone replacement therapy. And just like with feminizing therapies, it does take about 3 to 5 years to take full effect. Similarly, body fat may be redistributed 2 to 5 years to take that full effect. So the body fat will be redistributed to match a more masculine appearance. I'm trying to be as careful as I can with my language, since language matters, as we've established earlier on in the training, and we'll go into a little bit more depth a bit later on. Muscle mass and strength may greatly increase with 2 to 5 years to take full effect. In fact, one of my coworkers here at Caracol, who is non-binary on masculinizing therapies, they are a power lifter. And I do see, can you repeat the alternative term for menstruation? Monthly bleeding. Yes, that's correct. And Billy, do you know of any other terms that may be used in the community? I'll lean on you a little bit for this one.
I don't. It's I actually haven't heard a lot. Yeah. It is a good
That's
question.
fine.
Yeah.
I was thinking there was some more, but I may be remembering incorrectly.
There might be. It's been a long time since I've
Of
had
course.
it, so I don't remember.
And not being a member of that community myself, it's hard for me to recall off the top of my head. Excellent question, though, since language matters. Next slide, please. All right, so some of the side effects of masculinizing therapy, some of the most notable ones that you may not necessarily think of. Number one is acne. That is, I would say, a bit of a cultural milieu within transmasculine communities is acne. There are some of my friends that are attracted to acne because of its association with masculinizing therapy, strangely enough. There may be development of male pattern baldness, weight gain, potentially a rise in cholesterol, but the UCF guidelines, specifically those guidelines, are a little bit more, again, that's a controversial topic in the area of trans medicine. There may be an increase in hypertension. There may be that risk for type 2 diabetes mellitus, just like with feminizing therapies. There's also an increased risk of polycythemia, which can lead to some additional issues with too many red blood cells. But again, these are relatively rare. A slightly increased risk of blood clots. And then these last ones are the ones that we are a little bit more confident on, that we do see more consistently. Infertility, just like with feminizing therapies, not all people become infertile, and it may be reversible. I know a number of trans men in my life that have gotten pregnant and given birth successfully and safely. So infertility by no means is a given. Pelvic pain, we do see that one somewhat commonly, along with discomfort in the clitoris and drying and thinning of the vaginal or front hole walls. That's just one of the terms. There's a number of other different terms that folks use for their front hole as well, and you can refer back to our first slides in this section for some of that as well. With that drying and thinning of the front hole or vaginal walls, there is the potential for slightly increased risk of acquisition of HIV and other STIs. Since HIV, well, as most of us know on this call, has to have some kind of direct route into the bloodstream, and the vaginal front hole microbiome is very, very, very sensitive to any changes. That drying and thinning of the vaginal front hole walls can increase the risk of acquisition. There's also an increased chance of sleep apnea, just due to that redistribution of fats. People commonly on masculinizing therapies may have a buildup of fat around their neck, and that could lead to some issues with sleep apnea. Next slide, please. So now we're going to change gears a little bit and go into some of the surgical therapies that are out there. Next slide, please. So with feminizing surgical interventions, there's a list of a few, and I want to emphasize that rates of satisfaction in all of these surgeries are generally high. Any studies that have been conducted indicate that the rate of satisfaction is somewhere between 75 and 100% for all of these different surgeries. While rates of satisfaction for knee replacement, hip replacement, surgeries like that tend to be much lower. It's highly recommended in both the UCSF and the WPATH guidelines that folks do undergo at least 12 months of gender-affirming hormone therapy before they undergo surgical interventions. And that's just because that gender-affirming hormone therapy can lead to those desired effects that folks may be looking for without the need for surgical intervention, since surgical interventions do carry certain risks. So number one on the list is facial feminization surgery, including vocal cord surgery. So that would be from our friends in plastic surgery. That would be reconstruction of cheekbones, thinning or shaving of the Adam's apple, and things along those lines. The next one would be breast augmentation or gender-affirming breast surgery. So that's often in the trans feminine community colloquially referred to as top surgery. Next on the list is gonadectomy or orchiotomy. I will say after an orchiotomy or gonadectomy, which is removal of the external testicles, there is there's no longer a need. In the vast majority of cases, people can stop anti-androgens after that. So that's quite a common procedure and also lessens the medication burden on folks. Vaginal and vulvoplasties get a little bit more complicated, of course. There are a couple of different options for those. There's vulvoplasty and vaginoplasty that can be done with depth, and there are also options for without depth, also known as ZDV or zero depth vaginoplasty, in which case it varies a little bit from surgeon to surgeon, but that would be the case that a vagina is constructed, but there is no true depth to it. And again, not all folks are going to undergo these surgeries. In fact, again, self-disclosure, I have not underwent any surgeries yet. And there is, as we'll talk about a little bit later, Billy will focus on this part, there is some controversy in the trans community between trans folks about passing and being trans enough and things along those lines. And I do see that I have a question in the chat about masculinizing therapies. Is there any information on whether transmasculine folk experience menopause? So from the best of my knowledge, that's one of those things that seems to vary from person to person. I would say normally they do not, but it certainly is possible to experience menopause. Billy, do you have anything to add on that one? I must say I'm a little bit unfamiliar when it comes to that stage of life.
I don't know that I'll be that helpful. This was explained to me, but again, this was a few decades ago, and there's been a little more out there, but it's kind of explained to me that if a trans masculine person is taking testosterone, they're going through like male puberty and just like ovaries are just kind of taking a back seat. Not super helpful, but someone did describe it as you're going through puberty and menopause at the same time, but I don't have any scientific evidence that that's a thing.
And I must say that in my readings with the WPATH guidelines and the UCF guidelines, they don't mention anything specifically about menopause. So scientific evidence is a little bit lacking on that. We have another question in here. Is there an easy answer to will I lose sensation with surgery? And one that won't bog us down too much. And as for the latter part of that question, one that won't bog us down too much, I can't say that one for sure. It varies from surgery to surgery. And some folks just, unfortunately, as part of side effect of surgery, they do lose sensation, that there are some difficulties in reconstructing the nerves and things like that. I would say that's not a common experience, but occasionally that does happen with the surgical interventions. Okay, the other message was about the slides. Good deal. So the answer to that, if a client asks you that, you can't say, unfortunately, there's not an easy way to say yes or no, but more of it could happen through surgical interventions. But that would be something they would want to talk through with their surgeon a little bit more, so they can get a better handle on, say, the exact percentages that they're looking at. Next slide, please. All right, so I do want to put a note in here about free silicone and other fillers. So silicone injections, free silicone, are not uncommonly used by trans women to get some more immediate body changes in some form or fashion. So estimates vary pretty widely about the percentage of trans women who use free silicone and other fillers, from about 20% to greater than 50%. And medically appropriate uses of free silicone injections involve very, very low doses. While usually when free silicone is being used in a gender-affirming context, it's typically being injected by an unlicensed, or at the very least, a very unscrupulous medical provider, and it's being injected at very high doses. So the medically appropriate doses being less than 0.1 cc. There have been cases reported where free silicone has been injected at greater than 10 cc's. And that can lead to some rather significant dangers, which we'll go to on the next slide. So the medically appropriate use for free silicone is HIV-related lipodystrophy. I understand that a lot of folks may want those enhanced feminine features to pass and even help with survival sex work, and they may want that ability to achieve those feminine features without starting on HRT, but unfortunately, free silicone and other fillers are quite dangerous. Next slide, please. In fact, the true composition of those injected substances are usually pretty nasty and are often not medical grades. They contains things like aircraft lubricant, tire sealant, window caulk, petroleum jelly, a bunch of nasty stuff. And this is from our friends at the UCSF guidelines. The injected volumes on that, usually 1 to 3 liters a year or even more, far exceeds safe levels, and those precautions may not be in place. And those side effects that I mentioned are extremely, extremely dangerous and very acute. So we're talking about things like acute respiratory distress syndrome, sepsis, multi-system failure, loss of limbs, and atypical and especially severe infections. I would say this, coming from somebody that practices in a harm reduction setting, just like alongside Billy for years, there really isn't a form of harm reduction for free silicone and other fillers. The best that I would say is tell folks to reputably source the silicone, maybe buy it themselves even, and make sure that their provider truly knows what they're doing and are practicing as safe medical practices as they can to maintain as a sterile environment as possible. But just due to those side effects, overall, it's incredibly dangerous, and too dangerous to think about any significant harm reduction interventions, and start slow and low if possible. That goes with pretty much everything in the harm reduction world. Slow and low, absolutely. Next slide, please. All right, so masculinizing surgical interventions, changing things up here. So first we have a couple of different forms of bottom surgery. One of them being phalloplasty and scrotoplasty, so construction of a neopenis and a neoscrotum. And the clitoris can also be released through metedioplasty. And the clitoris can become quite enlarged with testosterone therapy, to the point that many folks can treat it as a penis, and with similar sensations most of the time. Like we were talking about before, with surgical interventions, we can't guarantee, unfortunately, a loss of feeling or enhanced feeling, since sometimes that may happen. But at the very least, that is one of the options. As Robin is saying in the chat here, it's a rare side effect of any surgery, just like with any surgery. Everybody is different. Everyone's results will vary. Some will have increased sensations, especially with the current newer surgical techniques, and results are getting a lot better than they have in the past. So thank you for putting that in the chat, Robin. As for what's colloquially known as top surgery, that's quite a common surgical intervention for trans masc folks. They undergo a mastectomy. Hysterectomies can also be considered a masculinizing surgical intervention as well. Some folks on the plastic surgery side of things may receive pectoral implants, and they may receive masculinizing face surgery with chin and jaw contouring and cheek augmentation in some form or fashion to make the cheeks a little bit tighter, if you will. Next slide, please. All right, so we're going to shift gears a little bit and talk about, we have been talking about standards of care for trans and gender nonconforming adults, but now we are going to shift gears a little bit to talk about standards of care for trans and gender nonconforming youth. One of the things, now that we've gotten through all of the binary things that I neglected to mention earlier, is these things can be done in any combination at any different doses. It kind of mix and match, almost, if you will. Many non-binary people may want to be on a lower dose than would be otherwise indicated for binary identified trans folks to achieve the effects that they're looking for. So that's why it's so important to be patient-centered and patient-directed when we're talking about gender-affirming care. So as for youth, the best practices were established 30 years ago in Amsterdam. And the vast majority of the time, youth are going to be offered puberty blockers to limit or hopefully eliminate the development of secondary sexual characteristics. And at some point, if a youth explores their gender a little bit more and figures out that, oh, they are cisgender after all, the puberty blockers can be stopped, and natal puberty, natural puberty, if you will, can start after that, usually within about 6 months. After puberty blockers, they may also start hormone replacement therapy, usually when they're 18 years or older. I will say some guidelines allow for folks starting gender-affirming hormone therapy as young as 16, but the vast majority of the time, folks are not going to start that until they're 18 years or older. So most of the time, they're just going to be put on the puberty blockers, which are incredibly benign, very few side effects. They are not well covered by insurance, which is a whole other issue, unfortunately, but they are benign. The effects are reversible. Puberty blockers, overall, they're not going to cause much harm to folks. Unfortunately, over the past 2 years or so, many states have proposed healthcare bans for trans youth. And unfortunately, this map is a little bit out of date. Here in Ohio, where Billy and I are, now have some of the strictest restrictions on medical care for trans youth, along with a proposal that's complicated, and I don't think anyone totally understands it. There's also a proposal that would limit some gender-affirming care for adults as well. So there's an incredibly complicated political landscape right now around gender-affirming care for trans youth. Next slide, please. Yep, thank you, Billy. This map was from November 2023, and things have changed significantly since then even. So we have another chat box discussion. Have you seen any rhetoric around trans health during this election cycle? I'll give you a hint. The answer is yes. In what ways was this rhetoric invoked? And for our friends that are attending from Connecticut, you have a much different political environment than we do down here in Ohio. How might election results affect trans and gender nonconforming people in Connecticut and in other states? And I'll let you all discuss that in the chat box. And then we'll move on a little bit to HRV and HRT. So while you all are thinking about that, I do want to go ahead and move on to that. So next slide, please. And next slide, please. By the way, National Transgender HIV Testing Day is April 18th, one of our big testing days that we celebrate in the prevention world. So first I want to start off just briefly, we'll get into the details of this a little bit later, but there is significantly higher rates of HIV infections among transgender folks. We'll get into the details of that later, but that's all you need to know right now. So we do know that adherence to gender-affirming hormone therapy correlates very closely with adherence to antiretroviral therapy and in turn viral suppression. Unfortunately, though, there was one study back in 2017 that found that over 40% of trans women living with HIV did not take their antiretroviral drugs as directed due to concerns about those drug-drug interactions, but less than half of them discussed that concern with their providers. I will say, working in the field of HIV, this comes up very, very commonly for me. Our case managers will refer folks to me in the prevention department to do a little bit more education with trans folks. And we'll go ahead and go to the next slide so we can start getting into this. And from what we understand, there is no evidence to suggest starting to lose my voice a little bit. Sorry, everyone. That there are any interactions between modern antiretroviral therapy and HRT. There are some older ART medications, specifically some NNRTIs and pharmacokinetic boosters that do have some effects with HRT, but they're not super well defined and pretty confusing. And on that same token, modern ART does not lower or in any way modify HRT's effects on the body. So this last note on here, this is another one of those very controversial topics in both HIV and trans medicine. There's some limited evidence to suggest that there are lowered levels of tenofovir, so TDF and TAF, which the brand names for those, I don't love using brand names, but just so everyone knows, TDF is Truvada, TAF is Descovy. There's some limited evidence that if somebody is on a feminizing therapy, there may be slightly lowered concentrations of tenofovir in their body, but it's probably not enough to be of clinical significance. We do want to emphasize here, 211 therapies are not FDA approved. It's not recommended by the CDC, but 211 dosing, we do acknowledge, has been approved in Canada, the UK, and Australia, and is an option for pre-exposure prophylaxis. So just briefly, 211 is somebody would take 2 doses of the PrEP 24 hours before sex, then 24 hours after, and then 1 additional dose 48 hours after, just briefly. So currently, it's definitely not recommended for trans women, and it is absolutely not recommended for cis women. I will say I was watching a conference back in December, a meeting of a lot of different experts in HIV here. They were discussing this very topic, and the experts said none of them would explicitly tell someone to stop 211 therapy just because they were on feminizing therapies. So it's probably best to approach this from a very harm reductionist lens to say if that's a way to get someone to take PrEP using that 211 dose, great. We'll go for that. So that was a very long-winded way of saying 211 is not recommended, it's not approved, people do it, and it's controversial. Next slide, please. And with that, we are going to take a little bit of a break here before I turn things back over to Billy. Billy, how are we doing on time?
We're at 59 minutes in. So we're going to take a 5-minute break. Oh, it's 2 o'clock on the dot, at least here on the East Coast. So folks want to come back at 2:05. We'll see you soon. Hey, everybody. Well, for anyone that came back, I recognize some folks are going to take longer breaks. Fully get that. Um, for everyone that's back here, we'll go ahead and get started on the kind of the second half of our presentation. One, if you are here and ready, can we go on to the next slide? All right. So we're going to talk a little bit about medical or some of the potential barriers to medical transition. And I feel like I would be remiss if I can't take a second to talk about the term passing. And Zoe did mention this a little bit already, but for folks that aren't familiar with the term or the idea, um, it can definitely be a contentious term. Passing is basically a trans person's ability to be recognized as their, for lack of a better word, chosen gender, or to not be perceived as trans. For a long time, passing was the norm in the medical community and also a lot in the trans community. There were these conversations like, when are you going to get on hormones? That was sort of almost like an end goal. I don't think that is the case as much now, but not being perceived by cisgendered people as trans has helped at times to keep us safer. But then by the same token, if we pass and then we're discovered to be trans, again by cisgendered folks, suddenly we're deceptive, or that opens us up to more violence and hatred. The idea of passing can create unwanted pressures to receive medical therapies. And, if we're talking about a trans person and they're not being recognized, like visibly trans, then maybe you want to think about some other terms. Perhaps someone is noticeably or not noticeably trans, or they are read or received as male, or read as female, or read as non-binary. Just I think that takes away that deception. And really the term passing just reinforces those gender binaries and a white supremacy culture. And Zoe, I don't know if you want to chime in on any of this, but please do feel free, as you and I chatted about it off this call.
Yeah, the only other thing that I wanted to add, Billy, is the term stealth. Could you talk a little bit about that one, Billy?
Honestly, to the best of my knowledge, because that wasn't really a term that was around when I transitioned. But as I understand it, it's like really people that are going out in the world that do not want to be perceived as trans. They want to be read as cisgendered. And there's lots of reasons for it. There are folks that do not accept the term trans. They feel like I was always this other gender, so therefore I'm not trans. There are folks that still do embrace the term trans on some level, but just don't want to, and they don't have to share. And there's lots of reasons for that.
Right. I was just going to add that both of those are more holdover terms from previous generations, if you will, especially like stealth. Back, 70s, 80s, 90s, the biggest thing when someone would transition, have their surgeries done, especially trans women, you'd see a lot of cases where they would get that final surgery and change their names, do all the legal designations, and then move and go to a place where nobody knew them, where they could start a brand new life. And that's a lot of where the stealth came from. Just fitting in as their new self, I guess, basically. And like you said, it's a lot of it then was more safety than anything else. Yeah. I'll just add to the passing, the best advice I ever got from someone was, I asked, how do you pass? She said, you don't. Because like you were saying, it's an energy of deception. And people pick up on that. And then some might look a little closer and notice a few things. And best advice I ever got as far as transition goes was not to try to pass, just to be myself. But that's just my experience.
Thank you. Yeah, I guess I don't think I realized it was an older term. It wasn't very prevalent in my community at the time when I started hormones. But language changes over time and regionally, so it's interesting.
It certainly does, and all that in as well, given my experience, and we are from, I think all three of us here are coming from slightly different generations. To me, stealth is a little bit more associated with the trans mass community rather than the trans femme community, at least for my generation. So that just really goes to show how pliable language is, and us giving this presentation today at the beginning of 2024, there may be a completely different take on language by the end of this year.
Probably. Yeah, I mean, it is a fresh new year. We're still in January. Lots happening. Yeah, thank you. That's super interesting though, because yeah, I feel like I've been out of the loop. If you want to go on to the next slide, Juan, that'd be great. I was gonna pass over this slide, but since we do have a little time, I'm just going to read a little bit about it, read a little of it. It's by Janet Mock. It's a quote, and it says, "The misconception of equating ease of life with passing must be dismantled in our culture. The work begins by each of us recognizing that cis people are not more valuable or legitimate, and that trans people who blend as cis are not more valuable or legitimate. We must recognize, discuss, and dismantle this hierarchy that polices bodies and values certain ones over others. We must recognize that we all have different experiences of oppression and privilege. And I recognize that my ability to blend as cis is one conditional privilege that does not negate the fact that I experience the world as a trans woman with my own fears, insecurities, and body image issues, no matter how attractive people may think I am." So, yeah, I just thought that quote really was a nice summary of why passing feels like a term that's sort of incongruent with living. And if we can go on to the next slide, that would be lovely. So Zoe also touched upon this earlier, but I want to talk a little bit about the concepts of informed consent and gatekeeping. These are both models used to give patients access to hormone replacement therapy and or gender affirming surgery. As Zoe was saying, gatekeeping may often be required by some clinicians, surgeons, or insurance companies, and requires various steps to show you're serious about medical transition. And again, that might have been a letter written by your a therapist that shows the patient's readiness to start hormones. I don't think it's as common now, but in the past, some of the gatekeeping included like living as the gender you were transitioning into. So that essentially meant social transitioning and trying to pass. So back, it's like circles back. And yeah, I do think some therapists would base their diagnosis on how long you did it, like 6 months to a year. I think we do see a lot less of that right now because more and more people are using the informed consent model. And again, that's where patients work in conjunction with their clinicians to discuss those risks and benefits of HRT intervention and surgeries if they consent to receive surgeries or services. I know back in the day, I went through the gatekeeping process, but Zoe, you mentioned your process was informed consent. And I don't want to put you on the spot, but is that something you'd be willing to share a little more about?
Sure. So I had a bit of a unique process, I will say, since I started transitioning while I was in college. I didn't live anywhere near, my parents didn't live anywhere near where I went to college. So I didn't have any relationships with medical providers in that city. I didn't know how to navigate the healthcare system because I was 20 years old. So I was incredibly lucky that the nurse practitioner at my college, she did her own research and she learned how to prescribe hormone replacement therapy and how to perform gender affirming care. I will say she did work in concert with my therapist on campus, but it wasn't a requirement of hers to begin my gender affirming hormone therapy. And for her, she did find, and if I remember correctly, I think it was through Fenway Health, which we have listed at the resources towards the end of the presentation for those of you who were following along. Fenway Health has a fantastic template for informed consent that lists off possible side effects along with desired effects. Increasingly, I will say the UCSF guidelines. I know I sound like a broken record referring to guidelines over and over again, but I'm a bit of a sciencey, nerdy person. I plan on going to medical school within the next couple of years, so hence why I love myself some guidelines. The UCSF guidelines say that you may not even need a formal informed consent form anymore. They feel that there aren't any significant legal protections afforded by that for practitioners. So now they can just gather verbal informed consent and document that in the health record.
That's cool. Thank you. Thank you for weighing in on that, Zoe. I wanted to say too, just on this slide, I wanted to explain the photos for anyone that is not familiar. The person on the top of the slide is a wealthy socialite, cisgendered woman named Jocelyn Alice Wildenstein. I think I'm pronouncing it correctly, but I don't know. And for anyone that does not recognize her picture, she had multiple plastic surgeries to transform herself into a Catwoman. The slide below her is a transmasculine person that has had top surgery and may have encountered some gatekeeping along the way. And I just want to ask folks, do you think that Jocelyn had to live as a cat for 6 months before embarking on her surgical interventions? And that's smart-assy, but all this to say, we give a lot more leeway to cis people to alter their bodies, and there's been a less for us. I also did want to circle back very briefly on a couple things in the chat, and I'm sorry I skipped through this when we were discussing passing. There was the conversation about passing not being lying, and it's not. I think that this is my interpretation of that. My interpretation of this thought is that passing is not lying. The deceptive nature comes from cisgendered people that feel lied to. I hope I'm making sense, and anyone else, feel free to chime in. Again, as I said before, passing has been traditionally kind of the standard. And for some folks, it comes naturally just from going through some of the transitions that they do. but the lying part really comes from how people view us. And yeah, Linda, I'm seeing you. We allow breast augmentation on young cis women without much regulation, such a double standard. Some folks might be shocked, but sometimes there are double standards in medicine. I'm sorry, that was very smart-assy.
That's why I'm going to med school, Billy.
I'm excited, Zoe. Let me know when you're done. Um,
I did want to add one more thing about
please
passing.
do. Yeah.
With this whole conversation, we do want to acknowledge that passing is a matter of safety. That the two of us, white trans people from Ohio, the two of us can sit here and opine on theories of passing. But for many of our Black and brown folks and other BIPOC folks, passing is a matter of safety. We do acknowledge every year we hold the Transgender Day of Remembrance on November 20th to mourn the lives of trans folks that we have lost to violence within the past year. And most commonly, it is Black and brown trans women that we lose to violence. And one of the most common stories is that they take a man home or whatever it may be, and the man finds out that they're trans, the man freaks out and kills them. So passing is a matter of safety for many folks just due to the cis heteronormative society that we live in. So I just wanted to throw that in there, just important to keep in mind with all of this that we're discussing today, Billy and I's particular viewpoints, and also just keep in mind that thread of our old friend intersectionality.
Thank you, Zoe.
And if I could add just really quickly that even if it's not necessarily about safety, because some people may have the privilege to be in a situation where they don't necessarily need to pass for their safety, but they just want to pass because they want people around them to perceive them as the gender that they are, right? So, and that to me is like the opposite of a lie, right? That's like the most truthful thing they could do, to try to present themselves as the gender they are, and to so that people can perceive them more accurately.
Yeah, absolutely. And I think that's like that whole, just the word passing, it stirs all of this up. Again, I mean, it's like, I sort of feel like we keep going back, but language is so foundational. I mean, communication, it's how we sense the world and communicate it to one another. So thank you, Zoe. Thank you, Juan.
It's also a word that our community didn't choose.
Good
It
point.
was a word put on us by more coming from the cis world, because passing says you're really not. You're just faking, right? For a lot of us. And true passing is you don't even have a concept that I'm trans.
Yeah.
Does that make
Yeah.
sense? I mean, for me, I worked at a trans organization for many years. I was a very big trans activist in the Sacramento area for years. And then I moved to a very small rural community where nobody even had a clue that I was trans. And I was never trying to pass or stealth or any of that. It just, because of who I am and how I was perceived, happened. And I think that's where a lot of this has come from in the past also. Some of these concepts are left over from 30, 40 years ago, when it wasn't so widely accepted or known, put it that way. I shouldn't say accepted because it's still not that accepted, but yeah.
Yeah, that's also an excellent point. I mean, I feel like I would love to just have like trans happy hour and really just break these things down even more in depth. But with that being said, I'm gonna go ahead and move on. And please, folks, if you have more that you do want to comment on, let the chat box be your friend. Zoe, I'm going to turn it over to you now. Juan, if you want to go to the next slide, that would be lovely.
Absolutely. So after all of my talk about medical transition and all of the fitting things into little boxes and going by guidelines, let's take it back. Not all trans people choose to medically transition. And there's no linear path, or there's definitely not a correct way to medically transition. And as I was mentioning before, you can kind of mix and match different things in medical transition. I would say it's becoming increasingly common that we see folks using low doses of different gender affirming hormones. There's a I don't want to disclose anything, but I'll just say there's a media personality here in Cincinnati that uses low dose gender affirming hormones that I know is a friend of mine. So it's becoming more and more common to use those lower doses of gender affirming hormones for folks that may be identified as non-binary, folks who may be exploring gender a little bit more still. That's becoming more and more common. Next slide, please. So there are, as we've discussed before, we're going to go through these kind of one by one, some very significant barriers to healthcare, from structural barriers, interpersonal barriers, and prior negative experiences. So now with that, next slide, please. Let's start off with structural barriers. So first off, trans folks are often uninsured due to discrimination in healthcare settings, discrimination from their families, things like that. It is very common that trans folks are underinsured. And there's further, as we've mentioned before, keeping that intersectionality thread through everything we think about. There are further increased structural barriers for bi and indigenous people of color trans folks. And further, as we discussed at the very beginning of things, and part of why I want to go to med school, there's inadequate training of physicians and other clinical staff on culturally aware and sensitive care. As I mentioned, I live here in Cincinnati, Ohio. I have easy access to a major academic medical center. I would be able to take the bus there if I had to. While where I grew up in rural Southern Illinois, there was no bus system. There was no academic medical center. And I believe even today, with the advent of telehealth and things like that, some of the restrictions that are being put in place around that would make it very difficult for me to access gender affirming care. So we see here, I believe this is it's from the 2015 US Trans Survey that we've referenced multiple times. You do see here that there's pretty significant disparities in the distance to a competent trans healthcare provider. We see that routine healthcare, you can reach that one pretty easily in less than 10 miles, but a not insignificant portion of people are having to travel 50 or even more than 100 miles to access transition-related healthcare. And I do want to open this again in the chat. What other barriers have you heard of or experienced yourself? And we'll go ahead, next slide, please, while everybody kind of thinks about that one. This specifically is from the US Trans Survey, and this specifically refers to one or more negative experiences with a healthcare provider in the past year, broken down by race and ethnicity. And we see here pretty much everyone is having some significant issues with healthcare providers. But we do note here, unfortunately, for those of us that are working in public health, I think this hits us pretty hard. Folks who identified as American Indian were experiencing some pretty significant negative experiences with healthcare providers. And I say that hits us pretty hard in public health, since part of our infrastructure in public health is the Indian Healthcare Service and other federal healthcare programs for indigenous folks. Next slide, please. All right, so one of the other things we want to talk about is anticipation barriers, this concept of prior negative experiences. So there is something called the minority stress model. Some of you may be familiar with it, but I do want to go over it briefly here. It provides a framework to conceptualize how stigma and discrimination create hostile social situations that result in higher prevalence of mental health disorders among sexual and gender minorities. There's 3 steps to the model. 1, Hostile interpersonal interactions resulting from an individual's transgender identity create overt stress and or physical harm. 2, the individual then learns to anticipate and watch for situations that may lead to repeated instances of that stress or harm. And then 3, eventually, the individual internalizes those negative prejudices and stereotypes held by society, leading to increased mental health problems. Among trans folks, those who hold additional marginalized identities, whether they are a person of color, whether disabled, any number of different marginalized identities, they have an increased risk of experiencing overt healthcare discrimination because of their gender identity. Notably, they are much more likely than white trans folks to be discriminated against. So folks, there's another thing I do want to note on this slide that I wanted to put in my notes. And I'm curious if Billy and Robin and Juan, if you all have heard of this concept before. There's this concept of trans broken arm syndrome. So I come into the emergency room with my broken arm, and I really need to get seen about my broken arm and get my broken arm fixed. But suddenly all of the questions that I get from my provider are about my gender identity. Yes, does my provider need to know about my medications? Absolutely. Does my provider need to know how I use my genitals? Absolutely not. Does my provider need to know if my family is accepting? What's your coming out story? Absolutely not. I'm there for a broken arm. I just need to get my broken arm fixed. Next slide, please.
I have had that experience, Zoe, where I went to a doctor, was in a car accident, had a broken toe, and they looked at my chart, saw my partner, said, "Oh, so you're transitioning. Okay, great. That's awesome. And wait, you're a lesbian? Well, how does that work? How does sex work between you two?" I'm like, really right now? I'm here for a broken toe. I just got hit by a truck.
That is sadly a common experience, and it looks like
It is. It's very
that's some
common.
thoughts too.
And I've also heard the term before, and it's funny because I think the last time I heard it was in a conversation about how similar it was to like fat phobia in medical settings, where you also go in with a broken arm. It's like, maybe you should lose some weight.
Right. Absolutely.
Thank you both for sharing that. I know that I think everyone on this call, other than Billy, wouldn't ever think of this. Here in Cincinnati, I have a primary care provider. I'm just going to brag on her that if you have any medical provider friends that need some additional training, look this name up. My primary care physician, her name is Dr. Sarah Pickle, and she's incredible. She's a cis woman, but she provides care to a predominantly trans population. And she exercises everything that we talk about in this training with being very culturally humble, only asking questions when she needs to. When I first saw her for gender-affirming care, she did ask me about my gender identity. She asked me about my partners and my practices to inform appropriate recommendations for STI screening and things along those lines. And she provides wonderful education here at the University of Cincinnati College of Medicine, and she's also a nationally recognized educator. So if there's any provider friends out there that need some additional help, look up Dr. Sarah Pickle. Shameless plug for her. She's incredible. Sorry about that. I just had to throw that in there. And on that note, one of the other things we want to talk about is the interpersonal barriers to healthcare. There is a quite incredible rate. So 24% of respondents to the US Trans Survey in 2015 said that they had to teach their provider about transgender care and about transgender people to get that appropriate care. And you can see all these different experiences that people have experienced coming in to see their healthcare providers. So it's common for folks to carry the burden of educating their healthcare providers on appropriate interactions in clinical care, which, okay, great for Billy and I, we're providing this training. I don't love doing that. I especially don't want to do that if I'm going to the ER with a broken arm, but say I'm going for a routine visit. I do webinars like this occasionally. I provide training internally to our staff. Do I have some capacity for that occasionally? Sure. But that's only because I do this for a living. Most trans folks should never, ever, ever, ever have to do anything like that to receive appropriate health care. Next slide, please. And I do believe I am throwing this back over to you, Billy.
All right. Thank you, Zoe. So we're going to talk a little bit about creating an affirming environment. We're going to go through this briefly. You know, as we said earlier, folks will have the slides. So some of this we would like for you to take back and hopefully discuss, you know, at your agency. But really, next slide, please. Creating a trans-friendly space helps to improve engagement and care with trans and gender non-conforming patients. And some questions to think about. Does your agency already have a diversity, equity, and inclusion framework? Does your agency protect and promote the rights of all gender identities and expressions? Does your agency try to increase staff understanding and acceptance of trans colleagues, volunteers, and clients? And does your do your trans and gender non-conforming staff and volunteers feel physically and emotionally safe in the workplace? Creating a trans-friendly space isn't just about your clients or patients. It's about the culture of your organization. If you have staff that feel like they cannot be comfortable as trans, how can you serve patients? And I can't stress this enough. Just because you have a trans person on staff and you have wonderful, you know, a wonderful trans-friendly workplace culture, it should never be expected that a trans person has to out themselves as trans. That is a very personal choice and not anyone else's to make. I wanted to mention again that lovely US trans survey from 2015, about 27,000 respondents. 77% of respondents said that they had jobs. In their jobs, they took active steps to avoid mistreatment at work in the previous year. 67% of the respondents reported negative outcomes when they were out at work. And then, of course, again, always compound that back for trans folks that hold more than one stigmatized identity. Next slide, please. So really supporting trans staff. I'm just going to mention a few of these programmatic developments and things to consider as you're trying to build a more trans-friendly culture. You can adopt policies that are trans inclusive. You can support staff in their gender transition. You can develop trans-specific diversity trainings. And you can utilize interventions that help support and nurture trans staff. There are 4 slides after this. I'm not going to go into them, but they touch a little bit more on each of these concepts. And so those are the things I'm hoping you'll be able to take back to your agency and think about and look at. Thank you, Juan. And then also talking about creating that trans-friendly or trans-affirming practice and for your program participants. Do you serve trans folks? How do you know if you do? What sort of questions are you asking? If your organization says that you don't serve trans folks, is it because of provider and patient relationship? Or is it because nobody told you that they're trans? That should be a red flag. Again, it should not be expected that a trans person disclose their status, especially if they're not comfortable. So again, back to language and how we talk to trans folks is important to collect this information. Oh, and sorry, Juan, if you can go down to 2 slides, the next 2 slides, or I'm sorry, forward. Yeah, perfect. I'm not going to go into this too much because this is going to be covered more in depth in our 4th session, but just ideas about making the space more trans friendly. And we've also mentioned this in terms of talking about pronouns and chosen names. We've talked about that in session 1, but making trans friendly spaces, there's lots of ways to do it. But essentially the idea is you want a space where someone can just use the bathroom that they want to use. And you want a space that when people come in, they know that they're seen and cared about. That can be flyers, that can be posters. There's lots of ways to do it. And again, we'll be touching on that more in the next session. Juan, if you can forward ahead 2 slides. So I just kind of wanted to go over again, gender affirming care. We've talked a lot about what that might look like. And really, again, I have to emphasize it's a very holistic, person-centered practice. Let's remember that there are valid reasons that a lot of trans folks don't trust or might shy away from the healthcare system and may not be comfortable talking about or showing their body. Instead of making it a buzzword, investing time into training and practicing trauma-informed approaches is really going to fit well into creating a gender-affirming, it's going to fit well into creating gender-affirming care because there's a lot of things that mirror each other. And again, can't stress it enough. Make sure you're mirroring people's language about their parts and their gender identity. Have that in the notes. Make sure that's accessible to other staff that might be interacting with your patients. Don't forget to take into account those multiple marginalized experiences and how they might affect your patients. What social determinants of health are your patients struggling with that are going to affect every other aspect of their life and medical care? And then, as Zoe was just saying, only ask what's needed to provide services and be clear and honest with yourself and your patient about why you do need to ask the questions you're asking. If you ask that of yourself, if you're about to ask a question and you pause and you think about, why am I asking this? And if you realize there is nothing about why you're asking that relates to the care of that person, then don't ask it. Another way to kind of work around language is using something called parts and practice questions. And that's really when we're discussing body parts or getting a sexual history, it can be very helpful because it's taking out the assumptions about gender and sexuality from your questions. So you might want to focus on a person's body parts and what they're doing with them. This might look like, instead of saying, like, do you have sex with men or women? Do you have sex with people with a penis, people with a vagina, sex with both? Is there any sort of risk of pregnancy for any of the types of sex you're having? Do you and your partners use any protective barriers like condoms, dental dams, gloves, PrEP? And then also, even just during sex, do any parts of your body enter your partner's body? Or do any of your body parts enter your partner's body? All these P's are confusing me. Probably because I'm rushing, I apologize. But what part enters where?
If I can, real quickly, Billy,
Please do.
I'm going to lean on Dr. Pickle again for this one. On my first meeting with her, when I first engaged in primary care with her, how she gathered this, She asked me what parts of your body are you using to love on your partners, and what parts of their body are they using to love on you?
Even better. Yeah. Yeah, it's I think that being less formal can really work in using these parts and practice questions.
I'll just throw in there real quick. One of the things I found in working with hundreds of different trans folks over 4 or 5 years in this exact setting, doing HIV testing, doing counseling for PrEP, that kind of thing. You have to ask sometimes some questions that seem kind of invasive. And if you take just a second to explain to the person why you need to know that information, they are usually a lot more open and receptive to answering your questions than if you just put the question out there. Right? If they know this is for their good or for you to be able to do your job better to help them, absolutely, they're going to be a lot more prone to want to answer your questions than necessarily thinking, oh, you're just asking because I'm trans.
Mm-hmm.
And it's intuitive, yes, but also like it took me a few months to recognize, like you were just saying, Billy, asking about parts. You know, HIV test counseling, we ask how many men have you slept with? How many women have you had sex with? Body parts, because not all women have vaginas and not all men have penises.
Yeah, exactly.
And that's exactly what we need to know for risk, not the other.
Yeah, that was I think that was something I had in my notes, but I erased them. But when you're doing HIV testing or healthcare, you want to know what viruses and bacteria are your patients being exposed to and how they might have gotten there, not necessarily the gender that came, like the body that it came on, the gender of that body. So I don't know. Definitely, if you can't answer why it's important, it's probably may not be important. But I think with that being said, and there are other ways, there's other forms of gender affirming care. There's other ways to do it. Again, we have a lot of references, and I encourage folks to kind of start looking around and reading and educating themselves more, and seeing how that can apply to your agency and your clinical settings. And I'm just going to go ahead and we'll move on to our next slide. We're going to slide home and I did make my sports metaphor. Sorry. I was trying to do one all day and I finally got it, but we're going to
Well done, Billy.
Data. What's that?
Well done, Billy.
I was waiting. I was trying. Anyway, Zoe, I'm going to hand it over to you.
All right, folks, I am going to bring it home with this note on data collection. I am going to go somewhat quickly through this since I think we do seem to have a rather engaged audience today. So I would love to try to leave a little bit of time for a question and answer session. Briefly, as Billy was starting to allude to, whenever we're thinking about data collection, you've got to stop and ask yourself a few questions first, because this stuff matters. And increasingly in these more dangerous political environments, those of you up in Connecticut, I'm not entirely familiar with the political situation in Connecticut, I must say, but I have a feeling it's probably not as transphobic as it is here in Ohio. So folks here in Ohio and Kentucky, places that I live and are close to my heart, trans folks may not want to answer some of these questions out of concern for their safety. So before you collect this data, stop and ask yourself why. What are you using this data for? Is the gender data necessary? Is it relevant to your services? Is it required for funding? Who will have access to this data? Very important in this age. Are you able to answer these questions if a trans person asks you directly? And unfortunately, as we've established, there are many trans folks that have been asked questions about their gender and bodies in a way that's very insensitive, unnecessary, ignorant, and at times even malicious. So that's why it's so important that you establish these things, that you establish these considerations before you move into forming new questions for different data collection. Next slide, please. We have a brief chat box discussion here, and I'll just go to the next slide, in fact. What question is the most accurate way to collect gender data? What do you think out of these? And you can also do it as more openly. You would rather have a different answer, but in brief, which of these do you think fits best? Oh, wow. Everyone is saying number 5. 5, but we use 4. Yeah, that one's, I understand that one. So yeah, absolutely. The standard of practice is number 5. And we call that two-step data collection. That we first ask what sex were you assigned at birth, and then what is your current gender identity. And the way to identify trans folks in that is to identify folks whose current gender identity differs from what they were assigned at birth. So that way we're able to still collect that data on the number of trans folks that we serve, which we know is so important, and we know can make a difference to the funding that we receive, and also helps us to identify different health disparities. And that's why, next slide, please. And that's why collecting data about sexual orientation, gender identity is so important. It lets us measure the quality of care that we're providing and see the populations that we're serving. And without collecting SOGI data, so sexual orientation and gender identity, we don't see the specific needs of LGBTQIA folks, and we can't identify those health disparities, and we may not deliver important care and other services. Next slide, please. So these next couple of slides, I invite you all, when you receive the slides from NASTAD, there's a direct link to Boston University's plan of implementation for SOGI data. I definitely invite you to refer to that. And there's also the RSR crosswalk resource for those of you who are using Ryan White Services data. Next slide, please. And in fact, let's go ahead and jump to slide 77, if we can. Yes, this one indeed. So just briefly, we've touched on HIV a little bit within trans and gender nonconforming communities. And just to emphasize, as with so many health disparities, HIV disproportionately impacts Black and Brown trans women, specifically Black and African American trans women. Next slide, please. And in fact, since we are running short on time and I want to leave some time for questions, let's go and jump to slide 81, if we can, Juan. I do want to highlight some of this data from the CDC, since I think this is pretty important and shows the disparities between cisgender folks that are living with HIV and trans folks. We see there's a higher rate of depression and anxiety, homelessness, missed medical appointments, and lower rates of medication adherence for trans folks. So we know how important this is to those of us that are working in the HIV field. Next slide, please. This is some local data for Connecticut. We see here HIV among trans folks, among transgender Connecticut residents, does disproportionately impact trans women, and over 70% of those folks contracted HIV through sexual transmission, along with almost 20% being sexual transmission along with injection drug use. Next slide, please. And then we'll go ahead and go to the next one. And I do want to just talk briefly about viral hepatitis. So it does seem that Hep C diagnoses among trans and gender nonconforming folks are approximately 3 times higher than that of cis folks. And that just signals some persistent and significant health disparities. That doesn't show that being trans is an independent risk factor for Hep C, but it does show that some groups within the trans and gender nonconforming communities are at increased risk for Hep C. Hep C is not a contraindication for gender-affirming hormone therapy, direct-acting antivirals, the treatment for hepatitis C virus. They do not have any significant interactions with gender-affirming hormone therapies. Next slide, please. Briefly, we know that in the 2015 US Trans Survey, the proportion of folks that were reporting illicit drug use within the previous month was nearly 3 times that of the overall US population, but it varies significantly among and within trans communities. The trans community seems to be an overall elevated risk for developing substance use disorder, generally due to that minority stress theory that we talked about a little bit earlier. But again, this seems to vary significantly from group to group within the trans community. Next slide, please. Here we see a little bit about respondents from the US Trans Survey that are working in the underground economy have a much higher prevalence of binge drinking, current marijuana use, current non-medical prescription drug use, and current illicit drug use of some form or fashion. So folks working in the underground economy seem to be much more prone to issues with substance use disorder. Next slide, please. And with that, with a whole 4 minutes left, I wouldn't say a ton of time for questions, but a little bit of time for questions. I want to close things out and just say there's no one way or right way to be trans or gender nonconforming. And there's no right way to transition or not transition. These are highly personal choices influenced by many different factors. Thus, the pathways to working with trans and gender nonconforming folks is not a one-size-fits-all, and it very much needs to be participant-centered and driven. The need to create an environment that feels safe and welcoming for trans and gender nonconforming folks is vital to serving a population that historically and continues to experience trauma and discrimination within mainstream healthcare systems. Creating this environment must start from the top down and isn't just about using the correct pronouns and affirming data collection, but truly needs to be part of the culture of the organization and agency that is serving folks. And with that, we have a little teensy tiny bit of time for questions. I do want to say thank you all for being with us this afternoon. Thank you for listening to my ramblings, since I feel like I got off track a little bit. So I very much do appreciate that. And we have slides of references here at the end, and these will be sent out to you all.
I also want to thank you, Zoe, for presenting today, and Juan and Robin from my team at NASTAD. Thank you for pitching in and chiming in.